My name is Tone Ikdahl. I'm the CEO of Lovisenberg Diaconal Hospital, and it's a great pleasure for me to welcome all of you, friends and colleagues in the auditorium and on Zoom for this seminar. And most of all, I'd like to welcome the Magic team who recently moved into our hospital in the building close by. We look really forward to collaborating with you. And we do believe that our hospital will be a perfect match with your principles. And together we will be able to show that your system works. Lovisenberg Diaconal Hospital has been an inner city hospital in Oslo since 1868, in more than 150 years. It is an ideal non-profit corporation owned by 2 diaconal foundations, and it serves a population of 200 inhabitants with public hospital services. Our population is a typical inner city population where we have a clustering of low-income families, drug addicts, people with psychiatric challenges, and so forth. And we believe that this is a good match with Magic. We have approximately 250 beds, a little less than 150 in somatics and 100 in the psychiatry wards, 1,600 employees, and an annual budget of 2.3 billion Norwegian kroner. Everything is public money, even though we're a privately owned hospital, and we provide public healthcare. I look forward to this day, and I look forward to understanding a little bit better what Magic is all about. So we look forward to all the presentations, and a warm welcome to all of you. Then I'd like to give the word to my colleague and the saxophone player, Anders Lerdal, who is our research director. The word is yours, Anders.
Thank you very much for joining us for this kind of celebration for our new home in at Lovisenberg, Villa Viten. You might have heard about Villa Viten, but for you English speaker, the Villa Viten has written like is Villa Viten, and also it reminds at least Scandinavian people from Villekulla, which is Pippi Langstrømpe's film, and also that also has something to do with signalize the joy and the play we have to do with research in order to.
Sorry, technical break. Okay. Slides are not showing for the people on Zoom,
okay,
so I'll try to fix that first.
Yeah. Very sorry. Yes, so this is a picture of the house you can see outside, and it has office places for 20 researchers, but we want to be an including environment. So we invite our colleagues at the hospital who want a research day, a week or a year, or perhaps many years, and also our national and international partners to come and join us and have lunch with us. For Lovisenberg Hospital, high quality research is important for our user group. Since Lovisenberg is not the biggest hospital in Norway, we have to focus on doing research on the group that represent our patients, our staff, and potential patients, and our hospital. So I think today we will give a couple of examples for research that is very much grounded in the clinical reality here. And we have to do research that is meaningful and make impacts for patients that are in our system and for our services. And that means in order to win external funding, we need to study the prerequisites we have at Lovisenberg in order to target our research to the biggest patient populations in our hospital. So like children and families in mental health care, and also, for example, orthopedic surgery. So you will have examples for that today. And also we active in involve users in developing the projects. So when we develop a project, all researchers and research groups, they have to meet for speed date with representatives from the users in our hospital. But also lately we have employed several users part-time or full-time in the study groups. Because you might remember a Lancet article published in 2019 about waste in research, and they concluded that a lot of research we do actually does not ask the right research questions from the perspective of the clinicians and also the patients. And also we do extensive quality assurance and has developed systems that really survey the results for treatment and also satisfaction at most of the clinics. But in order to develop and nourish creativity, we need to break down barriers that silos create. And silos at a hospital could be, as possible barriers could be between the professions, between researchers, actually between the clinicians and the researchers, and different science philosophies. So multidisciplinary cooperation and integration in research groups are very important. And when we introduced this in our hospital, we were very much in the line with the policy document that came from the Norwegian Research Council a couple of years later about how to break through new innovations. And one of the characteristics is that multidisciplinary and interdisciplinary research has that great possibility. And at the university, the research process ends in about when you come to dissemination. But doing research in a hospital takes it one step further into implementation. And that is going to be kind of the main topic for today. So just to give some examples about good and high quality research that we do in hospital. So we had Magic and Matchit research groups and projects that you will hear more about today. We have also a multi-center, multi-knee group trying out alternatives to orthopedic surgery. At Nick Wall Institute, Nick Wall Institute is an institute with long history from research, and they will also present part of their work and how they contributed to a Lancet report. At Unge Vettelsens Institute here in this building, they do a lot of research on gut microbiota and survey pathophysiology and physiology related to that. They also do a lot of tests for the hospitals in this region of Norway. And also we have a new project that has started at the Oslo University Hospital that will come to us, where we are in, which is implementation. Someone has to be muted. Yeah, I can go on because and in this implementation study we are going to implement best practice in hospital. We are going, based on that, we are sending reports to the primary physicians in our in the municipality and the areas that OS and Lovisenberg covers. And St. Olav Hospital in Trondheim is also a part of this. And this, we are going to follow this for 5 years and see if this has effect on treatment, on health conditions, prescriptions, and health economy. So this is a large project funded by the Research Council of Norway. Yes. And the last one is it's an interesting project, but that we have received funding from Health Southeast last year to look on oral health in advanced cancer patients. And this is a really exciting collaboration with the Faculty of Odontology. This is our neighbor building, and also they do a lot of tests at Rikshospitalet, the National Hospital, to look on the microbiology. And last, a large study that we have at the Clinic for Mental Health, Opening Doors. Yes, so I think I actually have used my time. So I will go on and introduce the next speaker, which is senior researcher and clinical nurse specialist, associate professor also, Maren Falch Lindberg, who will present us work in the multi-knee trial for patients with advanced arthrosis.
Thank you. Okay. My name is Maren Falch Lindberg, as Anders said. I'm a senior researcher at Lovisenberg and associate professor at the University of Oslo, and I will present a brief overview of the multi-knee team and how we work with developing evidence-based treatment for patients who are suffering from pain following total knee arthroplasty. And here you see the background for the multi-knee trial. It can be illustrated with this diagram. It is the main finding from my PhD study. The figure shows the trajectories of pain with walking during the first year following total knee arthroplasty. And as you can see, most patients improve significantly after a knee replacement. But we also identify a subgroup of approximately 20% who are just having temporal improvements up to 3 months. And then the trajectory shifts and they return to the preoperative levels of pain 1 year after surgery, which means that they didn't improve at all. So 3 months also represent the time point when they see an orthopedic surgeon for the last time, and also usually quit physiotherapy. So this finding is in line with the vast research out there on this topic, and these 20% of patients represent a quite big patient population. Only in Norway, approximately 1,200 patients every year go through surgery with questionable effectiveness of the procedure. So what do we do with them? Lovisenberg performs the highest amount of procedures, of knee replacement procedures of all hospitals in Norway. And we want to be a center of excellence for this kind of surgery in Norway. And now we identified a subgroup of patients which we are not treating well. They have suboptimal results.
So we believe that part of our responsibility to both to the society and to the patients is to take part in the development and the testing of better treatment models for these patients. So that's what we want to do. And these patients are also characterized by some risk factors. And here on the picture, you see Unni Olsen. She's a PhD student in the multi-knee trial. She's working on a systematic review to identify factors, prognostic factors to pain and reduced function 12 months after knee replacement surgery. And the long-term goal is to develop a screening tool to identify risk patients. So we are cooperating with co-workers at the Institute of Public Health on this project, and the review follows the PRISMA, equips for risk of bias assessment, and we use GRADE for grading of the strength of the evidence. As a spin-off, we also developed a new and innovative statistical method, which has been published recently as a preprint. So these results are not yet published, but the factors we identified were having a lower degree of osteoarthritis progression, symptoms from multiple joints, more preoperative pain, and a tendency of pain-related catastrophic thinking. And better preoperative mental health was a protective factor at 3 and 6 months. So it's already known that exercise therapy is effective for patients with knee osteoarthritis, both alone or in addition to total knee replacements. But how do we motivate patients to exercise if they suffer from depression, catastrophic thinking, which could lead to fear of movement? So we have planned our study with these factors in mind, and we have largely based our trial on this study published in the New England Journal of Medicine from colleagues in Denmark. And Søren Skau, which is the first author, is part of our team. So the aim is to test the effectiveness and cost effectiveness of exercise therapy combined with internet-delivered cognitive behavioral therapy in patients with knee osteoarthritis, either instead of or in addition to total knee replacements. And here's an overview of the study. It's a multi-center study with 3 arms, and we recruit patients from the 3 largest centers for total knee replacement surgery in Norway: Martine Hansens Hospital, Lovisenberg, and Kysthospitalet Hagvik. So patients who are candidates for total knee replacement surgery and agree to participate are randomized to one of 3 groups. The first group is a non-surgical group who receive education, 12 weeks of exercise therapy, and 10 models of internet-delivered CBT. The combined group receive the same intervention, but first they undergo surgery with a knee replacement. And the control group also undergoes surgery with a knee replacement, and they receive usual care follow-up with physiotherapy. So we follow them for 3, 6, 12, and 24 months. And we are currently recruiting, and last time I checked, we had included 112 patients, but we aim for 282. So there's a way to go. As part of my PhD, I participated in a 3-year summer school, European Academy of Nursing Science Summer School, which was funded by the European Science Foundation. And there I received training in development and testing of complex intervention. And this is a complex intervention. So therefore, we have planned our study in line with the MRC framework for development and evaluation of complex interventions. And we have now completed the first 2 phases, development and feasibility, and we are now into the 3rd phase, evaluation. So the exercise therapy program that we use is active with osteoarthritis, which is based on the Osteoarthritis Research Society International's evidence-based recommendations for osteoarthritis patients. It consists of an education program about osteoarthritis, and then they receive supervised and individualized exercise sessions 2 times a week for 12 weeks. And advice for lifestyle changes, weight reduction, if that's relevant. The internet-delivered cognitive behavioral therapy program has been developed by a multidisciplinary team consisting of nurses, psychologists, orthopedic surgeons, pain specialists, and psychologists from the multi-knee team. It has been tested in a feasibility study and evaluated by user representatives and further refined to a complete program in 2 versions, one for the surgical patients and one for the non-surgical patients. And the goal is to provide mental support for patients so that they can cope with pain and exercise and be active. And the work with the CBT program has resulted in a recent publication in the BMC Health Services Research. And here we see Turi Drongsvåg, which is also a PhD student and the first author of this paper. And the paper presents the development and of the program in 2 phases, results from the interviews with the users and all the changes that were made. The program is based on cognitive behavioral therapy, but we also lean to metacognition, ACT, mindfulness. In the program, patients meet a persona, which is called Katrine. She has osteoarthritis and she follows them through all the 10 models. The patients also see psychoeducative videos. They make their own goal pyramids, learn to use relaxation techniques, and perform writing exercises. They're also mentored by physiotherapists who call them every 2nd week. And here we see an overview of all the sub-studies in the multi-need trial. We don't have time to go into each one of them, but there are several exciting projects. So we're evaluating factors like quality of life, activities of daily living. We're evaluating the cost effectiveness of the intervention, and of course the screening algorithm and psychological factors. The study has received financing from several sources, among them the Research Council of Norway and the Western and Eastern Regional Health Authorities, Norseman and Lovisenberg Research Trust. So this project would not have been possible without such an excellent team. And here you can see some of them. They all deserve a great thank you. And here we see the team with names. Thank you for your attention.
Thank you very much, Maren, for presenting this study. And of course, this is based on the fact that Lovisenberg has the highest amount of this kind of surgery in Norway. So that's why we feel that we have an ethical obligation to develop research within this field. So I'm very happy to introduce the next speaker, Alexandra Havdahl. She is a senior researcher, but also an associate professor at the Institute of Psychology at the University of Oslo. I'm very proud that you were the first to receive a talent stipend from Health Southeast, and now she will talk about her contribution, her and the group page, to the work of Lancet Commission for Future of Care and Clinical Research in Autism. Welcome.
Thank you. I'm happy to speak today about my work at Lovisenberg to enhance the knowledge base on neurodevelopment and mental health, and also as part of the Lancet Commission on Autism. I'm a clinical psychologist by background with a PhD in the clinical assessment of autism and a postdoc in epidemiology and genetics. I lead the cross-institutional research group at Lovisenberg and the Norwegian Institute of Public Health, investigating the causes of neurodevelopmental and mental health conditions. So 3 years ago, I was invited by the Lancet to be part of their new commission on the future of care and clinical research in autism. For their commission, Lancet gathers a group of clinicians and researchers who are experts in their field with the goal of synthesizing the evidence across the field and also provide groundbreaking clinical guidance and advice to improve health policy and clinical practice. Lancet commissions are widely read and highly recognized by policymakers, health professionals, and researchers, and therefore have the power to move the needle on change in clinical practice. So, for example, the recent Lancet Commission on dementia changed some of the approaches to, for example, prevention in dementia. The Commission on Autism includes about 20 researchers and clinicians, as well as people with autism and family members, to ensure that their perspectives are involved. So the commission was going to be published 3 days ago and has now been postponed a month due to COVID disruptions. And I'm not permitted to talk about the content of the commission until it's published. So I had to refocus the talk today to focus instead on my work at Lovisenberg that has led up to the Lancet Commission involvement, and also my research my group's research aligning with the aims of the MAGIC team on improving patient care through trustworthy guidelines and evidence synthesis. So for those not familiar with autism, I'll just give some context about this neurodevelopmental condition. So Connor defined autism in 1943 with detailed case descriptions of children who showed difficulties both in social interaction and communication, alongside repetitive and restricted behaviors and interests. And it was often accompanied by intellectual disability. A year later, Asperger independently described other case descriptions of children who had similar social communication impairments and restricted and repetitive interests, but advanced language and intellectual skills. And it was only 3 decades later that these case descriptions were unified into a spectrum of conditions called the autism spectrum. And it's just worth highlighting that a woman named Dukareva, 2 decades before both Connor and Asperger described autism in a paper, but seems to have been forgotten by history since. In autism, there's a wide variability in severity, language level, intellectual functioning, and co-occurring difficulties and conditions. So research conducted at Lovisenberg has contributed and been instrumental in increasing the evidence on autism. So both on identification, diagnostic assessment, and course of development within individuals. And much of this has come out of the autism birth cohort study, for which the research clinic was based at Nick Vols Institute at Lovisenberg and was run between 2005 and 2012. So the ABC study was run in collaboration between the Norwegian Institute of Public Health, Columbia University in New York, and Lovisenberg Hospital. So we identified children with potential autism from an ongoing nationwide cohort called the Mother-Father-Child cohort study, also called MOBA. So MOBA is the world's largest cohort of mother-father-child trios followed from pregnancy. It includes more than 100,000 children and their parents. And the nationwide recruitment happened between 1999 and 2008. And we have rich data there both on genetics, environment, development, mental and physical health. So the families have been followed up at regular intervals from the pregnancy and up to the ongoing questionnaires at now age 18 to 20 years. So mostly it has been by a maternal report, but we also have report from the children themselves, the fathers, and also daycare and teachers for some measures. And so we have valuable longitudinal measures of development and health from birth to adulthood on this big sample. So one unique feature of the Norwegian system is that we have these Norwegian nationwide registries with complete follow-up of the population. So the MOBA consent includes permission to link to these registries. And so we have data on both pregnancy and birth, on diagnosis, treatment, and support received in all levels of the public healthcare system, as well as prescriptions. And we have data on national test scores in schools, grades, educational attainment, income, social security supports, as well as the family structure over time, housing and neighborhood characteristics. And so these registry data are useful both for enriched follow-up of the MOBA cohort and as part of that, the ABC cohort, but also to account for potential participation bias in responding to questionnaires in MOBA. So the ABC study, there we screened children from the MOBA cohort using the three-year questionnaire and an autism screening tool in that questionnaire. And we also invited children who had parents who were concerned about autism or they had an autism diagnosis in the patient registry. And we used gold standard clinical assessment tools and the recommended diagnostic evaluation of almost, or a bit more than 1,000 children. And the PhD students and postdocs in the ABC study, including myself, we were able to go for research visits and training at Cornell University or Columbia University in New York, which ensured the knowledge exchange between the ABC study in Norway and expert clinical and research environments. The researchers in the autism birth cohort study have published several papers showing how early screening tools for autism work when they are used in a general population cohort. So this is indicating that the tools that have mostly been tested in clinical samples, they are much less sensitive when used in a general population cohort like MOBA. We've also published on how US developed assessment tools work when they're used in a Norwegian sample and how you can use instruments based on different sources of information like caregiver interviews and observational assessments in combination to better identify children with autism. And we have also published on how autism is identified, diagnosed, and assessed in Norway, and how this diagnostic practice seems to vary across the geographical areas in Norway. We have also looked at patterns of medication use and comorbidities in Norway. I also want to mention some of the evidence in Thesis that we have worked on. So this covers a range of topics on neurodevelopment and mental health. So it's prenatal vitamins and the risk of offspring autism, mercury and prenatal growth, the genetic contributions to autism, within family Mendelian randomization studies, which are studies that use genetic information in order to understand the influences of the environment. and how to meet the challenge of multidimensionality within neurodevelopmental conditions, and the state of research within genetic epidemiology of neurodevelopmental and mental health traits. And of course, our goal of our research is that it will lead to changes, positive changes in clinical practice. And we've seen some implications of the work that we've done. For example, the ABC study research on diagnostic practices has led to a national training program to improve our reliable assessment and diagnosis across the country. And we've also contributed to improvements of screening and assessment tools. And there is ongoing work on decision tools that clinicians can use in practice. We also expect that the Lancet Commission may have impact on policy and practice. I'll skip a couple of slides to save some time. So since I'm not able to go into the content of the Lancet Commission, I will just tell you about some of the research that we've done and are doing now using genetic data to understand the influences of the environment with implications for clinical practice. So there are a range of parental traits that are associated with child neurodevelopmental and mental health. But many associations are likely to be non-causal. They could be due to, for example, shared genetics between parents and children. And there could also be reverse causality between these traits, so that children's neurodevelopmental and mental health problems can influence their parents' behavior and mental health. So we use novel methods to separate the genetic variants in parents into those that were inherited by the child and those that were not inherited. So this figure shows the genetic transmission. This is the direct genetic transmission, and we examine whether the non-transmitted genetic effects influence the child's neurodevelopment and mental health. We also look at whether the father's non-transmitted genetics influence the child's neurodevelopment. So since non-transmitted variants, they cannot be biologically expressed in the child, then any association between the non-transmitted genetics in the parents and the child's outcomes must be mediated by expression in the parental traits. So if we find evidence for parental non-transmitted genetic effects, the implication is that interventions may be usefully targeted to parental traits. And in the opposite, if we find only evidence for direct genetic transmissions, then interventions must focus on the child trait, as targeting the parental traits are unlikely to benefit the child. We don't only rely on this approach, we triangulate with several other genetically informed approaches and synthesize evidence across our own and other research studies. So we have 4 central aims, and the first is to focus on family effects on the child's development. And then we also look in the reverse direction, whether there are effects of the child's traits on the parents' mental health and behavior, and all accounting for shared genetics. And then we delve into the more specific and targetable intermediate processes between the parental traits and the child's neurodevelopment. And we finally look at how these associations occur over time from the child's birth to adulthood, to look at potentially reciprocal effects across development. So this was a whistle-stop tour of our research at Lovisenberg, looking at mental health and neurodevelopment. and how we aim to impact the evidence ecosystem in this field. I want to thank the research participants for making our research possible, and of course our collaborators and funders, and especially my research group at Nick Boles Institute and NIPH. Thank you for your attention.
Thank you very much, Alexandra. And you can hear from both of them the English that they've been studying abroad as a part of their PhD studies. So we are very proud of you, colleagues.